Giving it just a minute. We'll convene here in just a moment. Mr. Gladstone returns with us. All right, good morning, I suppose, still, everyone. Let's convene Opioid Settlement Fund Task Force this morning for June the 5th. Clerk, could you please call the roll?
Yes. Commissioner Strips,
Present.
Chair Ray, Vice Chair Pro Tem Hepler, Commissioner Morales, Director Rutherford, Director Nettleton,
Present.
Director Bobo, Sheriff Fuller,
Here.
Sarah Green, here, Director Gray, Susan Davis, here, Nicole Stortblum,
Here.
Dr. Ford, here, Brenda Henry, here, Leroy Gray, Dominic Gladstone,
Present.
April Anders.
All right, thank you, everyone. Okay, we will move to item 3, which is a review and approval of the minutes. I'd entertain a motion unless there are any revisions or comments. Mr. Gladstone.
Quick correction or clarification on the last page that I have, which is the section presentation idea from Health and Community, that section. It says Mr. Gladstone would like to rate and grade the grant request before it gets passed to the commission. That should read Mr. Gladstone would like the task force to rate and grade so that there's no confusion. I don't want to do it solo. Thank you.
Sure. All right, we can take that amendment. Any additional?
On page 3, it's third, I guess, paragraph. The last sentence, she said she would elevate the need for, and there's not need for what is my question? Because I wasn't here, so I don't know what was discussed.
Does anybody have any support for us to try to fill in a blank there, or? For transportation services?
Sorry, it's page 3, third paragraph, Chairperson Strabs, the last sentence says she said she would elevate the need for, and there's a blank.
Thank you so much for orienting me also. It's for transportation services because we were discussing the transit authority meeting. So we can add that.
Thank you.
Thank you for catching that. Any additional corrections to our minutes?
Motion to accept is corrected.
Motion made by Mr. Gladstone, supported by Sheriff Fuller. Any further discussion? All those in favor signify by saying aye. Any opposed? Motion carries. Minutes are approved. All right, this brings us to our opportunity for public comment. So members of the public that wish to address the task force are welcome to come to the podium. You have 3 minutes to share comments. Please share your name if you're a resident of Kalamazoo County, and opportunity to share your thoughts with us in a respectful manner. Anybody wishing to make comment, please come forward.
Hi, Nancy King, a resident of Kalamazoo County, also Executive Director of COPE Network and run Kalamazoo Harm Reduction. After reviewing and listening to the previous task force, there was a lot talked about with naloxone. And so I just wanted to update the task force on what's happening with naloxone in our community. We have been distributing naloxone around since 2016, doing a lot of education that goes along with that. And in the more recent concerns with the opioid overdoses, we started working and putting naloxone boxes where people can get access 24/7. We've been partnering with Bronson to put out many of those boxes. Just to kind of put in perspective, we have currently in April, we had 5 active boxes in Kalamazoo. In May, we added 2 more. In June, we're adding 6 more, and these are around Kalamazoo area, not just located downtown. And then we have 2 pending. Of those naloxone boxes, we have distributed over 335 kits just last month. I don't have May's information. So for April, that was 335 kits through the boxes. And we also have 1 vending machine in the Kalamazoo County Jail where inmates exiting can be able to get naloxone on their way out. It's important that we're putting these naloxone boxes outside. And that's because if people have access to resources or going into connections with resources, they're more likely to have naloxone. It's the individuals who maybe not connected to resources, may not be ready for recovery, that are at greater risk of overdose. So we want to make sure that we're getting out there the naloxone and understanding that we have been working very hard at being able to make sure we're seeing that out there. We're also seeing a little bit of a saturation, which is a good thing. I do a lot of education with people. I do go into rehabs to do education. I hear a lot of people going, oh, I've got 5 at home, or I've got whatever, which is a good thing. The concern is going to be for individuals who are alone. Obviously, they can't administer naloxone to themselves. So really getting that message out about, don't use alone, understanding the risks right now that we have to such tainted street drugs right now that's putting people at risk who may be using substances that they don't know contains fentanyl, and helping to increase the awareness so that they also are having naloxone available, but recognizing that they can use that. If they don't know if a person has used an opioid, they can still use naloxone on them. It's not going to hurt them at all. So we want to be able to continue working on getting that naloxone out there. Obviously, reports of use is probably the most difficult thing to get. We do work with a lot of law enforcement and providing naloxone to law enforcement in Kalamazoo County, with the exception of Kalamazoo Public Safety. They don't have to get their naloxone through us. And with that comes a lot of education. Those are reports that we do get mostly, not always timely or accurate in terms of their reporting. But the community is the hardest one to get information from. They don't think about calling us, letting us know they've had access to naloxone and therefore, and have used it so they can get a replacement, especially now they can go 24/7 to be able to get to a naloxone box.
Thank you, Ms. King. Appreciate your work so much. Thank you. Additional comments? Welcome to you.
Hi, I'm for the short people with tall stature, right? I am Pam Coffey. I am the founder of Healthy House, which is transitional housing for women. And I'd like to talk about that aspect of having a longer term care for women to come in. We work with women who are coming home from prison and coming out of treatment center. and they decided that they wanted to do something different and not go back to where they were before they went into whatever organization they went into. So we're finding some difficulties in opening up housing. And so that's one problem we have, where they put a lot of barriers in front of us to open up housing. And the second issue we're having is, how long can the women stay with us? A lot of programs want them to do 90 days, which is not enough. So we need funding that can support women for as long as they need to build a solid foundation. The goal is for a woman to come in, take care of that so that she can get housing on her own, because prior to that, we've done a lot of damage. I am a product of what I do. I am a recovering addict of 31 years. And when I came out of treatment, I went and stayed. Somebody suggested you shouldn't go back to where you came from. You should go somewhere else. So I rented a room. And I do believe that that is one of the key elements that has helped me to stay clean, that I didn't have to go back into the same environment that I left. So with that being said, 9 years ago, I opened up my first house. And it's been running pretty good for 9 years. I've had some success stories and some women who are still working on getting better. But what I have done is created a place where a woman can call me and we can talk about getting her to a safe place. The goal is to get them to a safe place where they could start over. So those are just some of the issues that I guess a lot of it is funding to have long-term services. My home right now, the women can stay up to 2 years. And so after 90 days, sometimes I'm not funded. So now I'm in the community and, looking for ways to keep them there, because some of the simple things I found out when it's time to look for an apartment, if a woman owes a consumer energy bill, nobody will give her a place. And that we don't even think about something like that. We're thinking about, did you have what is the biggest thing? If you got evicted, that's one of the biggest, that's another big thing. If you have an eviction, if you're in a felony, if you this and if you that. So the goal is to work them into a place where when they're out looking for housing, they can represent themselves well. They have a small history of, this is what I've done in the last year or the last 2 years. So thank you for listening. I hear that bell going off.
Thank you so much for
You're
your
welcome.
comments. We appreciate it. Any other members of the public wish to address the task force? Okay, seeing none, I'm going to move us forward to item 5. We're going to have a presentation from Dr. Nettleton, and here we're working on question 8, addressing is a countywide alert system and network collaborative needed to communicate with county residents when there's a cluster of overdoses or a deadly batch of fentanyl-laced drugs that occur within the county. Dr. Nettleton?
So I know Dina has some slides that are going to be shared. And so I think folks, oh, good, there's screens on each side so everyone can see. So go ahead and share those slides, Dina. So I thought to help inform this conversation, I could review our Kalamazoo County overdose cluster event that happened in April 2023, and also one that happened in Calhoun County in November 2023 to help inform this discussion overall. So I gave this presentation to a body of clinicians for continuing medical education in November, and so that's the context for these slides. So on April 13th, 2023, an overdose cluster event happened in Kalamazoo County. And so this is an overview of how this was identified, just to give a background from the public health perspective, the public health system overall. So Health Officer Rutherford and I received an email alert from the Michigan Department of Health and Human Services Drug Surveillance Unit saying, hey, it seems to be an uptick in drug overdoses. About a half hour later, we each got a text message from the medical director for the Medical Control Authority for Kalamazoo County saying, hey, we're noticing some things in public safety and EMS, and we're concerned about overdoses. Why don't we all have a meeting? So about an hour or so later, we had a meeting between public health, public safety, healthcare, hospitals, and county emergency management to discuss, what was happening in real time in Kalamazoo County. Valuable information from folks on the ground. Oh, still on the back. Thanks, Dina. Valuable information from first responders about what they were seeing clinically and responding to overdoses, and really important information that was coming at that time. Later in the afternoon, a critical care physician called the health department and said, hey, I have all these people in my intensive care unit, and they're not waking up, and they are presenting with a opioid overdose toxidrome, but they're also testing positive for cocaine. So that was a very critical report from a physician saying, hey, something's happening. So as you can see, when this happened, there was multiple layers to say, hey, there is something happening in our community right now. So next slide, please. So I thought if you'd run through just how do public health professionals think as further context. So first question, we asked, what are the facts? So go ahead, Dina. We can probably just put all the next ones. Just click through, Dina. So what are the facts? There was at least 6 fatal and an unknown probable number of overdose occurring probably in the last 20 hours. We confirmed that with our county medical examiner and with EMS public safety. What is the threat? The threat at this case was drug overdose. What are the consequences? Well, people were being hospitalized and the possibility for disability and death. What are the chances of this occurrence? It was unknown at the time, in real time, is this risk ongoing or not? How can we address this threat from a public health perspective? Well, it could be through risk communication and also harm reduction initiatives. Should we act now? Because could there be potential harm in acting too soon or potential harm in acting too late? And if we were to communicate, what would we communicate and when? This is just a general overview about how public health professionals think in an emerging public health situation. In this case, it was how to reduce a fatal overdose. So unknowns that afternoons, we knew that there was a severe overdose cluster event occurring in Kalamazoo County, hadn't happened before. There were at least 6 fatalities. There was an unknown number of people who were hospitalized, and all this has happened in the last 20 hours. The unknowns were, is this risk still ongoing? What exactly is causing the overdose cluster event, and who exactly is at risk? And that communication from EMS and physicians was really important for public health to form its communication about, it seems to be that all people who use drugs were at risk, not people who just self-identify as primary opioid users. Next slide, please. So at that point, back one slide, please. So at that point, reached out to our local harm reduction agency, reached out to our street medicine team, reached out to our county opioid coalition to say, hey, we are observing this. What are you observing? Please get out this information to your clients and to your patients as well. The health department also issued a press release about what we knew at the time and how to reduce risk. We also issued a health alert to clinicians, mental health care providers, and substance use providers as well. So that was the initial public health response. Next slide, please. And that response was ongoing, and our community responded with that information as well. So our local community agencies hosted naloxone pop-up events with that information. Our opioid coalition had situational awareness. Folks actually changed their 211 calling, and folks outreach to their clients in the community as well about the risk. Public health shared on social media about ways to reduce risk. I conducted media events and also interviews of raising the saliency of risk. Next slide, please. You can go ahead and just click through 4 times, Dina, and it should pop up. So this was the ongoing public health investigation. After the initial alerts went out and how to reduce risk, we did a public health investigation. We developed active surveillance with our hospitals, in other words, to send us information instead of waiting to receive it. I cross-referenced medical records from what we were seeing in the hospital and through our public health surveillance system known as MyCelerity. synthesized all of that information. And then we also had expedited specialized toxicology from a public health surveillance system at WMed that works with the state health department. Next slide, please. You can go ahead and just click through, Dina. So the overall assessment was that 18 overdoses occurred, 17 occurred within the city of Kalamazoo, 12 presented to an emergency department, and 10 actually presented to an emergency department within a time period of 5 hours. 10 were hospitalized, of which 8 required admission to the intensive care unit. So that's more than just the medical floor, that was the actual intensive care unit. The overall overdose cluster event resulted in 8 deaths, including a couple pairs of family members. Go ahead and click. Advanced toxicology indicated that this was both fentanyl and cocaine associated overdoses, not associated with xylazine. So the overall assessment is that folks who primarily use stimulants and intended to use cocaine only were unaware of the fact that fentanyl was co-present in the drugs, and that led to rapid opioid overdose. Next slide. The ongoing investigation and response included meetings, again, follow-up meetings with public safety, public health, and EMS and healthcare. I actually presented to the state health department as well. We issued a statewide health alert because this was a severe overdose cluster event. And we did a follow-up press release as well to update the community about what the assessment was. In this case, that folks who are intending to use cocaine were unaware of the presence of fentanyl and likely overdosed as a result of that fentanyl exposure. Next slide. I want to just touch on the Thanksgiving Day 2023 Calhoun County overdose cluster event. Yes, it did occur on a very early morning of Thanksgiving Day. Next slide. This was different. This wasn't at multiple locations that occurred throughout a single county that occurred, for example, in Kalamazoo, but occurred at a single private residence in the city of Battle Creek. Someone called 911, and in EMS arrived, 10 people were found unresponsive with decreased breathing. This was a mass casualty event, meaning that it required multiple agencies, multiple resources to address that number of people who were down at the time. 7 were transported to, or 7 made it to the emergency department, 6 of which were transported by emergency medical services. Folks mentioned they were intending, again, to use cocaine and accidentally overdosed, most likely due to fentanyl. 1 urine drug screen did show fentanyl and cocaine. So all of this kind of was similar to what happened in Kalamazoo. Again, but was different. It was a single location. And in this case, there was no hospital admissions and there was no deaths in this opioid overdose cluster in Calhoun County. Next slide. As a part of that response in Calhoun County, just as a reminder, I'm also serve as medical director of Calhoun County Public Health Department. We issued a press release on Thanksgiving Day about what our assessment was, how to reduce risk. A health alert went out again to clinicians and mental health and substance use care providers, and we initiated active surveillance with our local hospital. We also issued a follow-up press release after our public health investigation about what our final assessment was. Again, a follow-up health advisory to clinicians and practitioners as well, and follow-up media interviews about what had happened in that community, in that neighboring community. Go ahead and click through all those, Dina. So the takeaways from these overdose cluster events that occurred in neighboring counties, I would say is that people who use drugs should be aware of the potential co-presence of an unknown substance, such as fentanyl. In addition to not using alone or going slow, having staggered use or someone there with you is very important. As was mentioned, if no one is there to identify an overdose, then it increases risk of death. So for example, there was someone who called 911 in Calhoun County, activated a EMS response. It was resource intensive. There were those who did not use or co-used at the same time and then therefore overdosed at the same time, and that did result in deaths. So go ahead and click through again, Dina, a couple more times. There'll be a couple more that pop up. As noted, mixing substances increases risk for overdose. Fentanyl test strips may help reduce that risk. The coordination between public safety, EMS, healthcare, and public health communication can rapidly identify and communicate risk. And physician reporting of those unusual events was important, particularly in that first Kalamazoo County overdose event. Next slide. Which brings us, and calling 911 saves lives, as I mentioned, which brings us to this discussion that the task force and the board, or the board is presenting to the task force about an overdose alert system. So a couple different layers to that overall question. So in my opinion, what transpired in both Kalamazoo and Calhoun in terms of the response was good. We have good community relationships, good communications. I literally picked up the phone and called our community partners. And likewise, the other way around, that coordination amongst professionals across agencies. I do think there is a need for further discussion on a regional level with our medical coalition at Region 5 about how to standardize procedures across counties as healthcare systems, EMS, public health, we all work together across county lines overall, and that those discussions are ongoing. And I think that what the board is asking task force is about a different mechanism. We can clarify what that question is. Other jurisdictions across the country, some do have a sign up through a local health department or a state health department to voluntarily receive an alert once public health, most of the times, or public safety identifies a severe overdose cluster event happening, so they can receive an email or an alert. I've seen that. It is not a generalized alert. This is a voluntary, hey, I will sign up for this. If an event occurs, then I will be notified. That's typically how it's done in other jurisdictions. I'm not aware of a jurisdiction in the state of Michigan who does that, from my understanding. I can look a little more closer, but I'm not aware. So that's the context and background of those overdose cluster events and response that have occurred in our community and in neighboring Calhoun County. Happy to help facilitate questions or further discussions about this question posed to the task force.
Thank you, Dr. Netherlands. Who has questions they'd like to pose on anything we've heard here? Mr. Gladstone.
I guess the first thing that comes to mind is logistics. When you say, do we need this? It seems like we do. The question would be, what systems are in place that we could take advantage of that would execute it? You know, for instance, when there's a tornado, my phone goes off and I know I've got an immediate alert that there's a tornado. Is there infrastructure in place that would be able to be used and just plug into it or have access to it or be able to use it? Does that make sense?
I don't know the infrastructure. I would not recommend a community-wide alert. That would not be the way to do it. It would be, if the task force, if the board wanted to proceed with this, the avenue would be for private citizens to voluntarily sign up to a listserv. That's how I'd see this transpiring, as other jurisdictions do across the country. And again, our current response, I thought, worked very well, but it comes from the professional angle. You know, it comes from the professional side that then engages community members or clients, as opposed to the other way around as well.
Yes, Director Rutherford.
So we have listservs that have been created historically for different incidents. And, you know, when you ask, is the infrastructure there? It is to a certain extent. You know, there are obviously software and hardware considerations, but I think in play now, when we have a foodborne outbreak or something like that, we have different, you know, entities that we communicate with. When we have you know, an issue that needs to be heightened to the level of the state of Michigan, we have a Michigan Health Alert Network system that Dr. Nettleton alluded to. So, you know, the short answer is yes, the technology and the infrastructure is there. The longer answer is, the longer discussion is, you know, where do you want to go with that? There are, I think, systems that you can purchase that are, you know, specific to that. You know, school systems have them, so those exist. It's just a matter of how broad you want it to be.
Dr. Nettleton, when we're thinking about who we target with communications, can you help convey what is the downside to broader communications rather than just voluntary participation in an alert system?
when I think about public health risk communication or crisis communication, when public health communicates, I want people to listen. I don't want folks to say, oh, this is just another something in my inbox that I'm receiving. I want that attention to be there so it's not saturated, for a lack of a better word. And then something like a tornado, that's a risk to everyone, and it's an immediate, imminent risk when that comes out through radio or the National Weather Service. And so everybody is at risk. For this particular issue, not everybody is at risk. It's a particular population who is at risk. So I think about those two different factors.
Also some follow-ups. I wonder, when we're looking at the cluster event that occurred in Kalamazoo, as the communication tools were implemented, did we see additional overdoses come in after communications began to go out? Or was it already had it already occurred?
Excellent question. So the question is, does this intervention actually help? And that's the million-dollar question. It used to be, I was told, hey, don't communicate because that will encourage drug use. And I disagree with that assessment. People need to hear that they may be at risk. The question that I think you're pointing to is the communication effective? In both these events, the events are so severe and they happen so quickly, and then everybody knows fairly quickly. When I say everybody, maybe in the context of those who are using, that all of a sudden it stops abruptly, and people either are not using, or a person who distributes drugs illegally has pulled that, or public safety has interceded. And so in both these events, even though active monitoring occurred after that, we didn't see additional overdoses actually occur. But that difficult, like all public health situations, it's always unknown. There's always that unknown factor, and that's oftentimes informs the decision to communicate.
Yes.
Has there been any research from the individuals who we would want to reach with this alert, and like how they would want to be alerted and what's going to work for them?
I haven't searched the literature about that. It is a question about, people who, if this was a private citizens who would like to receive information, they'd have to be aware that this is something they could sign up for. They'd have to be aware or comfortable with receiving a text message or an email from a governmental agency about the situation. Those are the factors I think about. Will people know about it? Will people use it? And would they be comfortable from the agency that it's being distributed from?
And that was going to be an additional follow-up I had for you too, was around that comfort. If you're aware of some other jurisdictions that are utilizing sort of a text to communicate system, do you know strategies that they may have deployed to get people to enroll? Is it typically housed or communicated from a government entity? Is it done in another mechanism? Or where might members look to, if you know of like a community that's doing it where we could research?
I'm aware of governmental public health agencies, but oftentimes we, just like here in Kalamazoo, work very closely with community agencies that then distribute the information. As you saw, there's an assessment, and there's a professional level of assessment that occurs. We have had concerns come to the health department about an overdose event, and after assessment, public health has concluded there is not an overdose cluster event occurring. And so there is that assessment that does happen that I do think is important, if that makes sense.
Question if, I don't know, I hear government and I hear, as somebody who works for government, I hear lack of trust. And so I would wonder if too many individuals that we are trying to target would be too fearful that their information would be that kind of thing. And so they might not sign up for it. I I'm kind of like taking notes of things of maybe like doctor's offices, they go to see their doctor, and the doctor, amongst the many other questions you have to ask, is something like, would you want to be, especially if they know that they're involved with substance use, is this something you would like to be involved with? The schools, somebody mentioned the schools, and I wouldn't have thought about that until you said that, but like asking the schools, the parents, I mean, they might want to know if there's something going on that their kids might, get their hands on, treatment providers, obviously, you leave inpatient treatment, and would you like to be notified of this? The drug treatment courts, I mean, while that's still government, we would be able to ask them there. So I'm just concerned that governments aren't always the trusted resource, and people might not sign up for something when it comes to, oh, you're going to then judge me as a user or that kind of thing.
And a follow-up to that, the current systems I think worked well was that our coalition listserv, I sent out the alert to the coalition listserv, and we had a press release. So the information is out in the public to be distributed by individual community members or service organizations. So that process already will occur if a severe overdose event happens.
I was just going to ask where would we go from here with this discussion and information? What's the goal or resolution to recommend to move forward to answer the question in a way that gives some sort of action statement?
Thank you. I think what I'm hearing from our discussion is that there may potentially be benefits to a text communication to individuals in the community. It's a matter of sort of structuring how they connect with that service. And I think one of the other points as well is about, are there opportunities in a system like that, maybe Dr. Nettleton, that there's ways to communicate beyond what is just a public health threat, that we're seeing a big cluster that could potentially impact, a wide number of people. If we have a targeted communication system to help convey some situational awareness when there are maybe more known localized cluster. For example, I was made aware recently that there were some doses that occurred within KPEP within a short period of time. Or how and why those occurred, I don't have any information about. But would there then be opportunities where it doesn't elevate in the assessment to sort of that public health threat, or there could be communications to improve situational awareness for users or their support people?
That's an interesting question. As a background, there's always a background, unfortunately, there's a background level of overdose events that are happening in Southwest Michigan on a weekly basis. And so they're happening. And so when public health is alerted is when this is above normal. Like this is above the normal that we see that triggers a warning or hey, we noticed a blip, for lack of a better word. That's when public health becomes involved. Or a community member calls and says, hey, something has happened and maybe it hasn't been not yet into the system. And there's an assessment that's made through that route. We've done that and made a determination that there wasn't that level of background. So that's the issue overall. There are overdoses happening on a weekly basis in most communities. And so it's about discerning when it meets a level of threshold of risk.
And I think to add to that, it's important to remember too, that there's a lot of different entities beyond public health that are associated with this process throughout the beginning of disclosure or, determining whether or not it's an outbreak. There's law enforcement, there's first responders, there's the health systems. So it's not just, local public health or state health for that matter.
And that's where the Regional Medical Coalition, I think, having that further conversation too, to a standardized process, which again, I think worked well in both Calhoun and Kalamazoo counties on the professional assessment and communications end.
Griff?
So I can just say that during that event we're talking about, there was
a lot of communication with law enforcement. Chiefs were calling chiefs as soon as we were hearing some of this, and contacting our road teams. And again, most of them carry naloxone, and so they were alerted. But you know, none of it's there's not going to be one simple we push this button. You know, it's kind of like the tornadoes. When I was researching, talking to families that suffered through this storm system, what I found was their phones activated first, then they turned on the TV to Keith Thompson, and then they heard the sirens. And sometimes it took all three for people to go, this is serious. And I wonder, when we create any kind of new alert system, how do you make sure people take the first one serious?
So am I hearing from discussion, we have sort of a consensus to work towards implementing a text communication system in some manner that I think likely targets individuals who agree to participate, either, you know, offered that through the service providers and disseminated through through public health channels, but they're connected in that collaboration across a coalition with providers, families, schools, et cetera. We all on the same page there? Yes, Mr. Gladstone?
Just one quick question, adding to that list also some of the boots on the ground organizations like Ms. Nancy King's organization, Gwendolyn Hooker's organization, some of those boots on the ground that might hear word on the street that something's happening, that could be part of that, you know, is this happening, is it not happening, part of the discussion of is this urgent? Because it might come from the bottom of the food chain, so to speak, like word on the street is we've got a massive influx of xylazine. We need to send it up the chain to public health and to law enforcement. You know, we're hearing this from the street. So as long as that's included, I would say that would be a plus. So there's two-way communication. Some of the boots on the ground organizations hear about it before a lot of folks.
I think that fluidly happens already. I mean, I'll look to our audience about how that communication went. But we call each other. I mean, I think it's one plus we have in Kalamazoo County. So I think that is fluid. Again, we can do that. If I hear Commissioner Streb saying this is an interest, I mean, we can look at those other jurisdictions about what they do. And I don't look what those systems are. I just don't, I have a lack of knowledge. I know King County in Washington is one. I know Madison, Wisconsin. Those are both bigger jurisdictions, but it's a listserv, text serve function that's put in your name, not even put in your name, put in your text and your email.
And thank you for the discussion. I think that's been constructive, and I think hopefully we can move into action quickly. I think, you know, we heard last night at our Board of Commissioners meeting, and I think everybody here at this table is aware, just as, you know, in our discussion, overdoses continue to happen on a weekly basis. People continue to die as we all work through sort of a strategy and how we implement funds. So I'm hopeful that soon, you know, even as we work to compile longer term recommendations to the board, that we can be compelled to recommend some quicker actions that can be taken, such as how we help get more naloxone on the streets, vending machines out on the streets, get the communication out, while we think long term about how do we deal with prevention and intervention strategies ongoing. So with that, if there's any other comments that need to be elevated at this time, or we can move to administrative update.
I'll just make it official and make a motion that we move forward on this, exploring the text message system what's required monetarily and logistically.
Can I ask whose task that is going to be so that there's some clarity relative to expectations?
I mean, I can look at a list again of those organizations, and then maybe we can internally, I'd have to figure out how I don't know how those systems work. I can get a list fairly easily. Then the next layer is understanding how those systems work.
So what I would ask also is, we're more of a funding type unit right now, not a task, as best I understand things, right? We'll come up with ideas and we'll ask people to come up with, here, bring your idea to us. And what I would recommend is that we do some research and then say to the community, if you have the ability to put this together, we might be able to fund some part of this for you.
Can I make a suggestion that we ask Dr. Nettleton to work in unison with our health educator to explore some systems that currently exist and what they consist of, and the report back? It is June. It's June already. So maybe in July or August, we can come back and say, here's what's out there and this is what it consists of. And then maybe mirror that with, it may be as simple as, we've got the technology, we've got the hardware, we've got the software. It's a discussion about the process and how that works for getting people engaged and signed up. And then how does that flow into, our partners in the community, from, hospitals, on down to nonprofits. But there's, I think there's a little bit more complexity than we think there is as it relates to, this. So we'll probably need some time to kind of vet that internally and externally, and then come back with, a report as to what is out there and our recommendations moving forward.
Thank you, Director Rutherford. So to Dr. Nettleton, our health educator, is July too tight of a timeline?
Can someone remind me when the next meeting is?
July. Oh, boy. July 3rd.
I think to be safe, we may want to.
Sure.
Okay. All right, so we'll move forward with a report back on overview of existing systems and potential infrastructure or costs, maybe some process discussion by our August meeting. Certainly, if there's information available to elevate, you can make myself or Deputy Administrator aware of that as we work on the July agenda if it's available at that time. So whenever it's prudent to move forward. All right, thank you. Let's go to administrative updates.
I just want to make sure, because there was officially a motion on the floor, so I don't know if y'all need to
There-
do anything or if y'all are good.
We had a motion, but there was not support.
Okay.
So I think we have a directive at this time for report back in July or August.
Okay, perfect. All right, and that actually aligns pretty perfectly with I wanted to provide a financial report to y'all and then just kind of lay out the expectations of what I'll have for you in July. So right now, total revenue that we've received for opioid settlement funds, I'm just going to round for the sake of this, but I will email this out afterwards and provide it to the clerk as well for the minutes. But total revenue received is 4.6 million. That does include, we just received 1.4 million in allocation as of May 31st of 2024. Just so that y'all are aware, the settlement calculator that we have that gives us projections is, we're projecting to have received 1.8 million for 2024. We've received 1.4. I just haven't had a chance to dive into is this the uncertainty that we should be expecting of, we think it's going to be one thing and we actually get something a little bit less, or if there's an additional 400,000 that we expect to get at some point in time this year. Just as a reminder, expenditures for fiscal year 23 was 220,000. For 2024, it's been 44,300. Please note that the 2024 budget total was 272,900. So our fiscal year 24 expenditures represent about 16% of that budget, which is currently under target. That is largely due to, right now, there's 3 internal funding requests that the board has supported, 2 of which are position-based, one within the sheriff's office, one within the health department, and then the Office of Community Corrections. I'm like, I am not saying that name correctly. Okay, thank you. I had to look at the name over there. They have received some allocations as well, and those are reoccurring allocations. So total remaining funds available, excluding the 2024 budget, is 4.1 million. Again, I just want to make note that there are obligations that the board has already made for those reoccurring expenses. So one thing that I've asked finance to assist in is for the July meeting for us to have budget scenarios for y'all to be looking at. Of what could potentially be an annual budget or a budget for the next 3 to 5 years, as you were kind of considering and going through some of these questions, that can be something you can look at, which is loosely one of the questions that the board has pointed to the task force. I will want to note that allocated funds not spent do go back into the settlement reserves, in case that was a question anyone had. Again, as stated, for July's meeting, I will have budget scenarios for the task force to review. And then a question was raised last time regarding investment of funding. So I have raised this question to the finance department, who has spoken with the treasurer's office, and administration will be speaking with board leadership soon, and I'll have more information in the July meeting regarding that. As far as the task force and the resolution and the report, I think it was at the last month's meeting, y'all tasked me with compiling the notes and then compiling that report for you. So in the month of June, I'll be doing so for the 4 questions that y'all have pretty much tackled, and any of the others that you've kind of touched on. I'll be sending that out to y'all for review and asking for any input that you have. And again, having that part of our July meeting. If we're able to touch on it, it sounds like right now we have a lot to talk about in July, but at least it will maybe be in the packet so that the community members are aware of what progress we're making at this point in time. And then just as far as upcoming presentation, notes that I have is that we would like someone to come and talk regarding transportation barriers, a presentation regarding the Narcan locations and efforts. So I do appreciate Nancy King in the audience today, and stick around, I'm going to talk with you afterwards. And then of course, we've talked and discussed a little bit about the centralized hub or website for information. I know a number of y'all were at the Opioid Coalition meeting yesterday, where this was a topic that came up, and a discussion arose there for people to be kind of looking into that. What I gathered, and of course, Dr. Nettleton, please correct me here, but what I gathered from that discussion was a desire to not have duplication, and that there were a few people tasked with looking at the different resources that are out and about and available for a centralized hub or a website or a QR code to use that goes to like a Google Maps type thing, that there were people there in that coalition looking into that and providing research and circling back. So I'm just bringing that up for y'all right now. Again, that's kind of some of the discussion that I've heard. So I just wanted you to be aware of that discussion that was going on within that coalition. And then the only other thing I have is I was at a conference a couple of weeks ago with county administrators and deputy administrators, where I talked to a lot of my counterparts in other counties. I'll be reviewing some of the resources that they've shared with me, their websites, and even their grant application or RFP documents. And I'll be bringing forward some ideas or suggestions to the task force at some point in time. Probably maybe closer to August, since July seems like it's right around the corner. But at this time, that's the update I have, but if anyone has any questions or comments or feedback, happy to take it.
Thank you so much, Deputy Administrator Smith. Seeing no further questions there, moves us to item 8, additional resources. So these links are still available to us, the opioid settlement principles, resource and indicators. OSPRI, so this has been shared previously and just provides a number of different targeted approaches in prevention, intervention, and harm reduction strategies. And then also the Attorney General's opioid website detailing state initiatives occurring. Administrator, is there anything else that you want to elevate there? Just awareness for the task force, those tools are still available for your review and consideration to help our dialogues. All right, we've made it to the end of another discussion at this time. Do we have anything else for the good of our order that anyone would like to lift up or elevate? Mr. Gladstone.
The item I brought up at the last meeting, which was that the task force perhaps be considered a grant review and grading body. Can that be put on the agenda for discussion and a vote to see if we want to participate in that as we get community grants that are not, non-government when we open it up to the public and organizations? I think we've got a lot of experience on this task force that would be able to simply look at the grant requests and simply put a 1 through 5 rating on, the sections and what they think. And that way the commissioners have at least our input as they go forward for the final vote on whether funding happens or not.
The board would need to sort of reconvene or extend the authority of this particular ad hoc committee, which would be a vote of the full board in which to do that. But by consensus here, is there interest from this task force in participating in the review or grading for recommendations of future requests that come into the board? And then we can have future discussions with board leadership about considering that for a vote with the board, or what are our thoughts there? Is there interest in participation? Director Rutherford.
Chair, my recommendation is that either the board or administration or somebody identify the process of the grant process as a whole, because I don't think that that's really been articulated or even, I'm sure it's been considered, but what does that look like? We know what it looks like for the housing millage. We know what it looks like for the senior millage. We know what it looks like for the veterans millage. While this is different and unique, there also needs to be, considerations for, is this going to be an annual process? Is this going to be, open throughout the year? And I don't have answers to that, but I think that they need to be considered. The forms that the application process, those need to be developed. Is there going to be a portal for that? So I think that there's more than just who's going to do the review. It's everything in front of that needs to be discussed and, developed.
I think some of the issues you've elevated there are also due from us in our recommendation about sort of what the cycles will look like. What will our participation be in the process? I think it's duly noted, Mr. Gladstone, the interest and the potential collaboration, but I think working through our recommendations first with what we're tasked with, and then, perhaps that could be a recommendation within our final report that goes back to the board if it's the will of this task force. Okay? Thank you for that. Anything else? All right, appreciate everybody's input and expertise and perspectives. And with that, we are adjourned.